Hello everyone, friends, Real Steel is in touch. Alexander Evsev. Don't forget, it's me. Today in the studio with you is our already beloved guest, Pavel Popov. Pash, hello very much. I usually always ask guests how to introduce them. There is a doctor, a physician, there are scientific degrees. I don't think Pavel needs this. This is Pasha Popov, so you know everything perfectly well. This topic will be interesting. I'm sure all of you will find it interesting because some people use them. Some kinds of substances. We are not encouraging or promoting the use of anabolic substances. But anything can happen, so to speak, maybe out of foolishness. And very often guys face the problem that their lipid profile gets worse. Everything is in the red zone. It gets worse, the total cholesterol level increases. High-density lipoproteins decrease. Low-density lipoproteins increase. Triglycerides and the atherogenic coefficient increase. And immediately a lot of questions arise. This is probably one of the most common questions, probably right after hematocrit issues among bodybuilders on a cycle. What should you do about your lipid profile? Should I take statins or not? What should I take? Is this bad? Am I going to die tomorrow or the day after, or do I just have to live with it? Here is the lipid panel. Do the drugs have an effect?
The drugs do have an effect, but let's take a step back and start from the very beginning. Probably the most fascinating and interesting piece of news for me was it was truly interesting and quite revealing that I was actually doing the right kind of medical prescription, not just simply giving people pills for no reason at all. By the way, when would they even bother to check your total cholesterol levels at the clinic? What do you think about that? At what specific age would they start?
I don't know if I've ever had it done at the clinic at all. Total cholesterol. I really don't know. At what age? At what age? Just as part of a routine checkup on schedule? I don't know, probably never.
Basically, at 40 years old, you enter risk stratification. That is, there's a scale, the score. According to it, when you turn 40, the older you are, the higher your blood pressure, and if you smoke, and at the same time you have high cholesterol, depending on the combination of these factors, you can determine the probability that you will die from a heart attack or stroke in the coming years. And accordingly, just before you enter this chart, right before you turn 40, and it's clear exactly how to treat you according to it. There are treatment protocols, but before you get into this chart, a lot of people just didn't give a damn about your cholesterol.
Listen, I felt offended because I entered this chart. I'm 40 now. Nobody visited me or anything. The nurse didn't come to my house. I had to go somewhere myself. I turned 40 and nobody knocked. It's a bit upsetting. For some reason, I've already joined that category where there are potential risks.
Yeah, I don't think that do you actually use free healthcare under the compulsory medical insurance much?
I don't even have a medical card at the clinic. Not in the city where I used to live. Not in this city. I just don't have a card at all.
Yeah, really same here. So, and
here in Moscow, I have none at all.
That's why no one came. Yeah. So basically, individuals who were under 40 were kind of in a specific weird situation. Like, for example, they would conduct a comprehensive ultrasound scan of the blood vessels in both the neck and lower limbs. And they would check if everything was clear or not. If there were no atherosclerotic plaques or changes in the intima media thickness index, specifically in the carotid artery, then they basically didn't give a damn about their cholesterol and just went around with high cholesterol. Like, yeah, my cholesterol is high, but that's just how I am. That's just the way I am. I don't have atherosclerosis. To argue with them, you could say, let's do a CT scan of the heart with contrast. And if you do that, then in the coronary arteries, I think even by the age of 30, if you've had high cholesterol since you were 20, by 30, you'll already see something. Some plaques, atherosclerotic ones. Interestingly, the first place you can look for plaques, well, this is kind of a joke, but actually the first to get clogged are the penile arteries. Pernicium
doesn't work because of that.
They're affected first, suffering even before the heart's coronary arteries.
You may have heard that story, that because of cholesterol, your penis might stop working.
While this is often seen as an age-related issue, theoretically, it could also occur in a much younger person. So it turns out that these people were left out, and they still remain left out. I just looked at the most recent scientific study, and it indicates that it's highly recommended to regularly monitor the level of, I'll tell you exactly what in a second, starting from the age of 20 years old. In other words, we check cholesterol not from age 40, but if you suddenly end up at the clinic, if you happen to go there, but from age 20. And if indeed there are abnormalities, then statins are prescribed, and sometimes in quite a high dosage. Here we're talking about medications. We'll talk now about how they can be switched around and about who reasons in what way. But the idea is that starting from age 20, if there are any deviations from the norm, they need to be corrected. Another point. What do they look at now? You mentioned LDL and HDL.
Triglycerides, atherogenic coefficients.
Yes. And this crap doesn't work anymore.
I see. Thank you.
So now it's all about LDL. Yes, they remain a significant factor. And there are specific fragments of LDL cholesterol that are considered the most atherogenic, the most damn atherogenic ones. That is ApoB, which is a transport particle. So now they look closely at the ApoB of the lipoprotein, specifically the LDL, and the non-HDL cholesterol indicator.
I need to remember that. I'll review it myself later or write it down for her. Is this diagnosed in a regular lab? Or do you have to go somewhere to some fancy-ass lab?
No, it's a regular lab. And there's one more indicator they add, which you can get tested once in your life. It's called lipoprotein A. If your lipoprotein A is elevated, that's a separate risk factor for atherosclerosis. And so you see it in your results once in your life. Lipoprotein A is high, and that's it. Just take statins. So basically, such people are already considered to be in the risk zone. I've had situations like that. Doctors, when it comes to prescribing pills, especially those that have a bad reputation among the public, like statins, for example. I once had a very wealthy patient under my direct care. He was a quite well-off person who rarely ever showed up for his appointments. And he was also being closely monitored at another clinic, like a real professional hospital. It was a really big one, and they also, they definitely want more money too, right? So they decided to sell him a similar service as well, sort of like monitoring, and we had a call with them about it.
You had a call with them about this person, right? Between yourselves?
Yes. They thought that...
How are we going to treat him? Are we...
No. That is exactly what I thought. And they were planning that it would be some kind of total mess. Like they would see some guy talking about pharma, but they really don't understand shit. But it didn't turn into a mess. But I had a question for them. Why did they, to the person, he was over 40 already. His lipoprotein A was elevated. I said, so where are the statins, for fuck's sake? And they go, well, he's still young. Supposedly his vessels are clean. I'm like, well, fuck it then, whatever. Like, do as you wish. That's it. So for some reason, some people, they don't pay close attention to some minor details, but they definitely ought to. Meaning, if there's such an indicator, then we treat it. And right away, let's talk about statins. Now, statins have been very extensively studied, both inside and out. They remain the drug of choice for treating dyslipidemia. They're included in all the protocols, so accordingly, what can happen from them? Quite a few people experience these symptoms. Some minimal increase in ALT and AST. Mostly it's consider older gentlemen and ladies whose livers are no longer functioning as well as they once did. Maybe their detoxification isn't working so well anymore. They're prescribed various statin medications along with therapy for their chronic conditions. Because by that age, many people have already accumulated a whole bouquet of diseases. They're prescribed statins and their ALT and AST go up a little. It happens. And sometimes people complain that when you take these pills, you get this feeling in your muscles, like they're either cramping or just something unpleasant. And basically, if you report this, they switch you to some other medication. These drugs do not have any serious or significant side effects, like literally none at all. That's why, by the way, the overall tone and attitude in all of the literature is very serious. And moreover, when we use, say, 10 milligrams of rosuvastatin or 5 milligrams of rosuvastatin, in general, when high doses are required, for instance, if clear signs of atherosclerosis are found, doctors often prescribe up to 40 milligrams of the same rosuvastatin medication. And what exactly is the primary goal of this treatment? If a person has had a stroke, a heart attack, or if a large plaque was found on their ultrasound, then they need to lower their LDL to a certain level, around 1. Basically almost to 0. That's it. That's why there are preventive medicine doctors who say, damn, what are hormones going to be synthesized from? No cholesterol, what about hormones? Well, somehow, damn, they still get synthesized. People aren't dying from it. That's it. Sometimes they talk about testosterone loss, like testosterone will drop when taking statins. The evidence is weak and, well, roughly speaking, if your testosterone drops, well, just inject it, damn it.
Inject it. Why overthink it? So, a few questions right away before we get too far off track. You mentioned that amylase test, the ApoB1, right? Well, in a regular clinic, nobody's going to do that for anyone. That's just how Pasha is. Popov reviews the research and examines his patients more thoroughly than most. Nowadays, in a regular clinic, they probably just check total cholesterol and that's it. So how are people supposed to get treated or diagnosed? Not everyone can come to Pasha Popov for a consultation, right?
They can listen to the broadcast, and those who, specifically this is lipoprotein A. These are the ApoB fragments of lipoprotein A, LDL. And consequently, we look at non-HDL levels. It says cholesterol non-HDL. So these are the 3 indicators, if they're outside the normal range, and a neck vessel ultrasound.
But you said that even clean vessels are not always a guarantee.
Yes, that is, which means that as the years go by, they may continue to stay clean. Here.
Why the neck vessels? Is it easy access for diagnostics? Why? Or is it some kind of cross-section that something is always noted here?
Yes, it's just convenient. Well, that's how they examine the neck and the vessels of the lower limbs. That's it. And accordingly, they determine the main blood flow. So what's the idea here? Once back in cardiology, during my residency, there was a man whose both carotid arteries were blocked by 95%. And if you called his name, after about a full minute, he would eventually go, what? Basically, his brain just wasn't working at all, simply because the blood wasn't reaching it properly. And that's exactly why the plaques themselves were so problematic. A question that is often asked is, if you already have an atherosclerotic plaque, can you reduce its size or even remove it entirely through the use of statins? Yes, that is actually possible. You cannot remove it entirely, but you can certainly make it a bit smaller and much more stable. This is because the plaque itself is basically made up of low-density lipoproteins, and different cells form around them, sticking together and on top as well. There's a kind of cap, like a plate made of fibrous tissue. Calcium deposits can also form within that area. It's an endless debate, like vitamin D for people on anabolic steroids. Calcifications. It is a rather interesting thing. If the calcifications are substantial and well developed, it is a clear sign that the plaque is stable and that it won't. What exactly are we afraid of? Not only can it block the interior lumen of the blood vessel, but it can also break away and fly somewhere else. And
worse?
Well, it depends on the situation.
It's better if it's stable, fixed in place, and not going anywhere. Or if it's unstable, there's a risk it could break off and travel to the brain or the heart. So which is worse?
Yeah, I would say stable is definitely better.
But then it could block the vessel's lumen, right?
Yes, but you can start taking statins. In this high-dose regimen, it can slowly begin to regress and eventually become slightly smaller in size. So basically, the main strategy when these plaques are detected, the goal is first to make sure they don't grow, and second, if you're lucky, to make them smaller. That's it. And here, in addition to statins, well, for example, if a person doesn't want to take statins, we tell them, okay, so for statins, the second-line drug, that is, with the same function of lowering blood lipids, is ezetimibe. It's also known as Ezetrol or Otrian. Those are the brand names. It simply disrupts the absorption of cholesterol in the intestine. As a result, cholesterol in the blood drops significantly. This goes against standard dietary recommendations, which suggest that your blood cholesterol levels actually depend only 20% on the food you eat, and the rest is internally produced by your body.
Synthesized by the body itself, right?
Yes.
Well, there is this common misconception that fatty foods high in cholesterol aren't necessarily a direct factor provoking dyslipidemia.
Yes.
So you can eat lard every day, but you still won't have high cholesterol.
Yeah, and then you give someone a pill that prevents cholesterol from being absorbed, and it drops. Like, it just goes down like that.
And here, the followers of this whole hormonal balance story might chime in as well. If you don't let cholesterol be absorbed, then testosterone drops too, and well, your manhood goes with it.
No, in cases where you prevent absorption, cholesterol doesn't drop as much as it does with statins, so it's a milder medication. It's usually added when, for example, someone was first given statins and then complains like, I'm not feeling well on them. They either discontinue it or reduce the dose. And then they add ezetrol. Or, for example, statins have given a good effect. But they really need to significantly reduce their levels of cholesterol, either by half, or to a specific value around 1.0 for low-density lipoproteins.
Total, or specifically the LDL fraction?
Low density.
That's what they specifically target, right?
Yes. Total cholesterol is actually calculated from all the others we've discussed, and that's why total cholesterol doesn't matter at all.
Doesn't matter.
Yes. So the main thing is these particles. LDL around 1, that means your atherosclerosis will stop progressing. And
do you also need to work on increasing HDL at the same time? Should you even be looking in that direction?
In that direction, it turns out you really don't need to do anything at all. I mean, there were drugs. They just never made it to the market because they were ineffective. Basically, they made drugs to raise HDL. They raised HDL, but the mortality risk didn't decrease. Not at all. So HDL, like low HDL, just means you're overweight or on anabolic steroids. And that's it. That's all low HDL indicates. And the strategy of raising it is absolutely useless. For example, I removed it from my own screening because I don't give a damn what it is. I'm going to lower LDL in any case.
But what about people obsessing over omega-3 to raise HDL?
First of all, omega-3 doesn't actually increase HDL. Second, many people don't quite understand what they're talking about. It happens. So basically, HDL is just completely pointless, accordingly omega-3. Omega-3, it has properties to reduce. After all, for a vessel to be damaged, there must be some reaction to damage to this vessel.
Lowering pro-inflammatory factors, no?
Yes, yes. What this means is there must be a certain level of inflammation or insulin resistance. These are the two primary underlying factors that allow low-density lipoproteins to securely attach themselves to the interior of the vessel wall so that a plaque can start to form. And that is exactly why if, let us say, we have a less than ideal overall body composition and metabolic health, then the entire progression of the disease begins to accelerate significantly. All of this will happen more and faster. If the body composition is good, then, for example, I once had a patient. It was quite a long time ago, but I have mentioned him more than once. He was on a strict keto diet. And Dr. Berg, the very well-known expert,
yes,
Dr. Berg, he says, like, it doesn't matter, eat a lot of fats, but you don't have insulin resistance. And that's why you won't develop atherosclerotic plaques. So this guy came in, he was like a real vegan, and then the keto diet, back and forth. A vegan.
And a keto diet?
Yes.
Wait a minute. So how did he actually get his fats?
Plant-based?
Plant-based?
Yes.
Keto vegan, I mean, that's a pretty wild mix.
Well, anyway, that's how it turned out. Then he was, well, he wasn't a bodybuilder, of course, but actually he was in pretty good shape. I mean, he was kind of lean, ripped, tall. Honestly, I might even say maybe at some point he did a cycle, but he looked good, and we made an agreement with him. So he had been in that condition for 4 years already. So he likes the keto diet, he sticks to it, yeah. And his LDL, just so you understand, was 15.
15?
I mean, maybe it was 16, 15, 14. I might be mixing it up, but I definitely remember it was way over 10.
Oh, wow, that is actually quite a lot.
That's a lot.
Just so people understand, that's a lot.
That's a lot. And I was like, listen, man, you really need to consider going on statins. And he goes, well, I don't have insulin resistance, so my blood vessels aren't getting damaged. So I said, well, why don't you go get yourself checked out properly? And he did the test, checked his neck and checked his lower limbs, and everything was completely clear. So I said, well, if that is what you really want, apparently you should just keep on doing exactly what you are already doing. Because damn, what else can you even say to that? So the specific factor that triggers this whole reaction leading to the formation of an atherosclerotic plaque is really strongly influenced by insulin resistance. And also things like viral infections, having had COVID, and various other factors of that nature.
The elasticity of blood vessels should be good. If the elasticity of the vessels is poor, then that's an additional provoking factor. And as I understand it, even with high cholesterol, with high low-density lipoprotein, if there are no additional provoking factors, people live and feel perfectly fine.
Yes. Because of this, some people even try to completely undermine and discredit the benefits of testing cholesterol and monitoring it. But in reality, there is practical real life. And there was this one guy who honestly was on a keto diet for 4 years. In all my 15 full years of work, I've seen it. The rest of the typical keto dieters, they do keto for 2 months, then 2 months of God only knows what. And that is precisely the reason why they raised their LDL levels and then ended up with such a case of anti-insulin resistance. So naturally something develops there. So that is the situation. And that is exactly the reason why we have statins. We have Isitrol to help statins, to put it in more simple terms. Right here, Isitrol. Sometimes I prescribe medication when a person comes in and their cholesterol is a bit higher than it should be, well, just a little. And I know that he, let's say, is currently being monitored and observed in some other clinic. He's so committed, or, well, to put it quite simply, where they will definitely say that statins are bad. If a doctor prescribes statins, then he'll have this dissonance because over there they'll be filling his head with stuff like statins are harmful, while I'll be saying, actually, this is according to protocol. So he'll be left wondering who's right, and well, basically, it turns into a tug of war. I really don't need that at all. So I say, here, take Isitrol. You take it, the cholesterol doesn't get absorbed, at least partially. Some of it will still be absorbed. You can't block it completely with just one pill. Like, not all my cholesterol got absorbed. Fuck it. So basically, only part of it doesn't get absorbed and everything in your blood turns out fine.
Yeah, once again, it's this incomprehensible crap. So high cholesterol, they've always said all my life that it doesn't depend on dietary preferences, so to speak, cholesterol. But you say it works.
Right, yeah. I mean, it's a second-line drug in the guidelines.
So where does all this hysteria around statins come from? On the contrary, it's a real medication with research behind it, which proves that it works.
You know, I even once asked GPT this question, like, why are statins considered bad? Because, well, they have described mechanisms, like, for example, they lower the level of coenzyme Q10 in mitochondria, but that's not critical. And if you want to be, well,
at least alive.
If you want to be really advanced, just take coenzyme Q10 along with statins.
No, if the risk of lowering coenzyme levels is there, but you could potentially have a heart attack because an atherosclerotic plaque ruptures and breaks off, then it is perfectly clear which way you should choose, right?
That's right. Yeah, but you always have a choice. If you have a ton of money and you happen to hear from someone else that statins aren't right for you and, well, like that they're actually harmful, then you have two other drugs, Repatha and Tebrova. These are monoclonal.
Injecting.
Yeah, these monoclonal antibodies have been shown to work remarkably well. They come with absolutely no side effects at all. Repatha costs $15,000 for one pen, and you need one pen every 2 weeks. Well, once every 2 weeks. You get an injection every 2 weeks, so that's $30,000 a month. And Tebrova costs $130,000 per pen. You get the first injection, then the second one 3 months later, and after that, once every 6 months.
Yeah, that's definitely something for the rich.
You could ask your friends to chip in for your birthday.
After 40, that's exactly when I've already entered the risk zone. Guys, I'll send out the wish list, and Tebrova will be on it. Who can afford it?
Everyone can pitch in 10,000 each, and that'll work.
So that I can at least make it all the way to my next birthday. One of the complaints about statins was that basically it's a one-way ticket. Like, you know, with hormone replacement therapy, they say you can't just stop. Like, for example, if my levels are high, I start taking it, and if I suddenly stop after 6 months, it'll get even worse.
It won't get any worse, meaning everything will go back to the way it was. So basically, the longer you take this medication, the better your cholesterol control will be, and accordingly, your future outlook will improve. If at some point someone fills your head with nonsense and you stop taking the medication for a month or two, well, during that time your cholesterol will return to its original levels, and that's worse because those lipoproteins are floating around again, and they can start sticking to the vessel walls. Then someone reasonable will tell you that it's actually okay to keep taking it. statins, you start taking statins again, and nothing terrible will happen. So let's say you have, for example, the rest of your life left. Well, how much do we have? Well, for me, GPT chat didn't promise. That's when anyway, 9 months ago, GPT chat promised me 2 years of life.
Yeah, and honestly, I think I'm completely done talking to GPT late at night. He's telling you some kind of nonsense.
9 months have already passed. I'm still here, so I'm fighting back. I want to win. Artificial intelligence.
To beat artificial intelligence with statins.
But that is not all. Look, you still have some remaining years of your life left to live, say 40 years or even 50 years, if you spend at least 20 of those years taking statins. Well, this essentially means that your vital blood vessels will be much better protected and reinforced, so your overall risk of dying from a sudden vascular wall spasm or a dangerous blockage is significantly lowered. Against the background of an atherosclerotic plaque, it will become smaller. So just take some, damn it, and things will already get better. But the idea that we get hooked on them, damn it, we don't get hooked. Like, I just don't understand people who use the word get hooked. Getting hooked is when I come up to you and say, listen, bro,
I got some pink statin. Want some?
you want to take a little sniff?
Pink statin, yeah.
And like, I push this thing on you and you're like, damn, that's some cool stuff. And I'm like, yeah, it's cool. So now from here on, it's for money. That's it. And like, but here you come in, you have high cholesterol and you could die from it. And they tell you, you're fat, you bastard. And
That's it. They send you home. They just say, you're fat, you bastard. Stop, screw it.
they prescribe a pill and they give you a pill. I mean, the pharmaceutical market has finally reached the point where it can actually give you a pill that will, damn it, substantially extend your life. Just take it all the time.
But again, for money. See how it is? Again, for money.
Well, do you know how? Here I am, ordering pink statin from a pharmacy. Well, like, they deliver to your home, so it's convenient. They have all kinds of pills. Here's a pink statin, for example. Here's Cristor, original drug. It is expensive. For example, I take a pink statin. That's exactly what it's called. Pink statin. 193 rubles per month.
It's bearable.
Whore.
This can be strengthened.
And I don't really give a shit. That is, it works. All falls to blood, all is well.
So it turns out that statins can be taken by people who don't have direct indications like, say, elevated cholesterol levels. But if, for example, this minor, then what? But at that moment, LDL will be normal.
But if,
However, statins can be taken.
yes, if,
What out of why? Because of what? If, say, LDL is low and there are no provoking factors.
there have simply been studies demonstrating that these small A lipoproteins are an independent risk factor for atherosclerosis.
Even worse, right, than LDL.
Yes. And so if they are present, it means you should take statins. What's there to think about? You just go and take statins.
But why is it so complicated? Why is it so complicated? Is it really some kind of super expensive, super exclusive test? Why hasn't this test been included in the standard diagnostic checklist a long time ago, just everywhere, not just total cholesterol at the clinic, but adding these 3 tests as well? Why was it so hard to do this?
I've no fucking idea what's happening in clinics. Maybe.
But actually, doctors in private clinics do not do this.
Well,
At best, it's just an extended lipid panel.
yeah. And, well, it's just honestly kind of sad.
Well, you know, it's like with diagnosing hypogonadism, it's the same story, right? Where sometimes the doctor might not even check SHBG,
They just don't go into detail, yeah. But, well, honestly, to be fair, the simple reality that your cholesterol levels already need to be carefully monitored and managed starting from the age of 20, I clearly remember a specific moment from my childhood. We were driving along with my dad. My dad is also a doctor, and my mom is a doctor too. And back when this whole thing with statins was just starting to appear, he said, I don't even know what to think about it. He regularly performs ultrasounds and frequently notes, with my patients who are on statin medications, it seems like they have a higher incidence of cholesterolosis of their gallbladder walls. And he says, I talked to some surgeons and they say that with statins, these atherosclerotic plaques are somehow, well, either it's harder to operate on them or something else is going on. And that was actually the very first time I thought, And I hadn't even started university yet. And then later on, well, everyone kept trying to find some kind of potential harm from taking statins, but in reality, there really isn't any harm to be found. And if there are no side effects like the ones mentioned above, then you can safely take them. And all of this really does prolong life. And in pharmacology, the emphasis is exactly on what you were talking about. In pharmacology, LDL increases, ApoB increases, and as for small lipoproteins, they don't care about pharmacology. If they're high, they're high. If they're low, they're low. And accordingly, HDL decreases. And so the main thing is that a lot of health-conscious people invest in this. Damn, I've personally seen people who eat 10 or even as much as 20 grams of omega-3 every single day just to
I know, yeah.
raise their omega-3 levels, HDL to be precise. It's pointless, to put it mildly. That is all. And there is also the omega-3 index as an important indicator.
Indeed.
That's it. The omega-3 index, probably
Do you check it?
I did not use to check it regularly because, I considered omega-3s themselves when they first appeared, and people talked about them quite a bit. You know, this whole story from the Kolenchenko clinic. Omega-3s were originally positioned as specific drugs that lower bad cholesterol and raise good cholesterol levels. And all the extensive studies on this topic have shown that no, nothing like that actually happens. There is absolutely no effect at all on those levels. In other words, the lipid profile doesn't change because of omega-3s, no matter how much you take. And taking more than 4 grams of omega-3 per day increases the risk of arrhythmia. Well, in adults, that is. I didn't really look at the omega-3 index because of this, but then I realized I wasn't being completely honest with myself. In what sense? For example, I order a homocysteine test for people. Homocysteine, if it's elevated, is associated with risks of thrombosis and so on, atherosclerosis. And homocysteine is showing a great deal of promise. There are many clinical studies about it that show it can, really predict certain medical events, but it hasn't yet been included in the official guidelines and isn't fully evidence-based. So, in standard clinical practice, say in the United States, across Europe, or elsewhere, doctors typically won't order it unless you specifically request it and pay for it yourself out of pocket. They just won't order it because there simply isn't enough clinical experience with this specific marker yet. And its overall value in accurately predicting whether something will happen or not is still considered very low. The only thing with homocysteine is that for some people, there is hereditary hyperhomocystinemia because they have a mutation in the folate cycle and they lack vitamin B in its active form. And those individuals really do urgently need to take B vitamins to lower their homocysteine levels. And in their case, homocysteine levels can actually be 40 or 50. Exactly. And that can really cause harm. So homocysteine is something I've always promoted as an important factor, especially for athletes using pharmaceuticals, or if besides pharmaceuticals, you're also taking some other harsh substances, then it really shoots up a lot. And as for omega-3, I looked closely at the statistics, based on the latest scientific research. The omega-3 index, that's a measurement which I never prescribed because, I thought omega-3 supplements are just complete bullshit and so on. Yeah.
All those supplements of yours, right?
Yeah. Basically, omega-3 has about the same level of evidence as homocysteine. And I'm thinking, damn, out of the two, I somehow picked homocysteine. I prescribe it, but I do not prescribe the omega-3 index. And I chose in favor of, there were two options. To stop prescribing homocysteine or to add the omega-3 index. And I kind of thought, I'd rather just add the omega-3 index because, that's evidence-based medicine for you. But sometimes it often lags behind actual real-world events. And it often... Take a look at this example. With vitamin D. I always bring up how the recommendations for its use have changed. At first, no one talked about it at all. It was only given to children for rickets. Then suddenly, recommendations started coming in from America by the hundreds saying you need it. And I remember, those types of gatherings, various sorts of professional meetings. DNA has these specialized meetings for doctors. They're called lab trends, doctors get together. And there someone gives some lectures, and mostly it's about some new tests that are being done and so on. So basically it's educational, and at the same time it's kind of networking. And I remember how doctors would say, damn, I got my patient's vitamin D up to 100, and some illness went away, especially something like serious skin diseases, some kind of dermatitis. And then it went away for him, even though it never did before. And holy shit, a vitamin D level of 100 is just life-changing. Then they said it was all bullshit. So they set it to 40. When I saw the latest recommendation, I saw that 40 is the upper limit. And then by chance, and kind of on that note, so that was about a year ago. And a year ago I saw that 40 was the limit, and I thought that's probably how it's going to be. 40. And I aimed for 40. Then there was a video. Who posted it first? DZ Zarya uploaded it. About how if your vitamin D is below 30, you don't get the effects of testosterone. The positive ones. And then Dr. Brin recently released a video, I'm sure you've seen it too, where he clearly proves that the current standard norm for vitamin D is 20.
Honestly, I think 20 is just too little. I honestly don't know. I mean, I haven't really read all of those smart articles yet, but it just seems to me like 20 is actually kind of low, don't you think so?
They believe that 20 nanograms per milliliter is absolutely essential to prevent osteoporosis. Like, so your bones remain strong and healthy. And beyond that, like, who the hell needs it?
Should you take it as a supplement? For prevention, 2,000 or how much? 5,000? Or did no one used to take it before? Yeah, and orally.
The prophylactic dose is considered to be 600 to 800 IU. So just a tiny bit, right? Well, to be honest, I think I still really want to stick to, well, a level of about 40. I try to keep people at 40. So I prescribe depending on how a person's vitamin D level increases with an oil-based tablet or a water-based solution. Accordingly, I prescribe a higher or lower dose to reach the target values. That's it. And we stick with that. And well, it seems to work pretty well. But what I mean is, and for example, varicocele. Back when I was finishing university, the consensus was that varicocele was a total disaster. People said sperm quality would be bad and testosterone levels would drop. Basically, everyone was told they needed to have varicocele surgery. Then new studies came out and suggested that this varicocele scare is bullshit. Nothing new actually happens there. Basically, whether you have varicocele or not, we looked at sperm analyses, they're the same. And then again, they said that varicocele is a disaster, it needs to be removed. And even though now the indication for removing varicocele is basically when you can feel it and it bothers you, so it's not just that you have this vein on your scrotum, but you actually feel it. Like, you have pressure, I don't know, however it feels.
It even started to feel kind of unpleasant. Why did you start talking about this?
And that's when they remove it, and well, everyone already knows this, right? By now, just about everyone has been discussing these proteins in their diet. The fact is, the pyramid has been flipped. Before, the base of the diet was made up of slow carbs, and now proteins are supposed to be the foundation of nutrition. Before, you would build your diet with protein at about 1.6 to 2 grams per kilogram of body weight. Yeah. Then 0.8 grams of fat per kilogram, and the rest would be carbs. So you'd end up with slow carbs, like 200 to 300 grams. And now, like, you can slam in 2.5, even 3 grams of protein.
The only thing I saw is that the FDA, the American Food and Drug Administration, says that the modern person's diet is actually very deficient in protein. It's not that you need to increase it, but you just need to pay attention to it and at least bring it up to the minimum recommended level. Because they believe that the average person, whether in Russia or elsewhere, even in the West, doesn't even reach the old recommended norm. It's not like someone is pushing for 2.5 grams of protein. Come on, who can actually do that? Probably only bodybuilders can manage that. No one else really could.
Well, yeah. And well, there is a trend right now, and it will likely continue to exist for a long time. And that's why people who rush in whenever something new comes out, like some new document, sometimes medicine turns into this thing, like you're the coolest and the best if you're the first person to read some brand new clinical guideline that just came out. Then you tell everyone about it and just sit there patting yourself on the back. So that is basically what all of medicine feels like right now. Yeah, looking at it from that perspective, I usually prefer to just wait and see how things develop. Like, I'll see what came out and who has already tried it out.
So you don't embarrass yourself later, yeah?
Because that's exactly how it was. I remember how awkward I felt, for example, when there was the insulin theory of obesity,
Do not tell me you actually supported it.
Yeah, I actually prescribed different foods to people based on the insulin index.
Tell me that was like 40 years ago or something like that, right?
It was a really long time ago. Back then I was talking to nutritionists.
All right.
And then, well, I kind of realized that, it wasn't like that at all.
All right, anyway, since we're on this topic, I actually used to set up my own diet based on the glycemic index too. Yeah, so that's why it's exactly the same thing,
Yeah, that's why this kind of thing happens. But with atherosclerosis, it's important. Even if you're not an athlete, you still need to keep an eye on it. When we're on gear, we say that the lipid profile gets worse. We don't give a damn about the drop in HDL. The main point is that LDL is low. And that is exactly why the atherogenic coefficient depends so much on HDL.
Yeah.
So when you see a high atherogenic coefficient, but your LDL is at around 1, then you don't give a damn about the atherogenic coefficient.
The atherogenic coefficient is total cholesterol minus HDL over HDL. And when you don't care, the calculation gets messed up.
Yeah, exactly. So you just look at the most important factor here, the ApoB particle. That's really the one that actually gets deposited in the vessels. LDL is a bit less significant, but it is still very important. Lipoprotein A is a whole separate thing entirely. And so often people just use the non-HDL indicator.
They're not included in the extended lipid panel. You have to order them separately, right?
Some labs include them, some don't. So basically you just need to specify which ones you need. Ask which panels they're included in at your lab and make sure everything gets done.
Before this, the guy had normal cholesterol levels and all its fractions. He started taking medication and everything went into the red. He then decided to add statins. Shortly after he stopped taking the medication, he completely eliminated that provoking factor. How much longer does he need to take statins, or does he need to at all? And that's the situation.
In principle, you can stop them right away. That is, as soon as, well, let's say, give yourself, if he had long-acting esters, then they linger, they stay in the blood for about 2 or 3 weeks at some residual concentration. So after taking them for about 2 or 3 weeks, you can discontinue them. So if he had a good lipid profile on statins while using gear, then on a cruise he can keep them. And testosterone doesn't worsen the lipid panel, and in some people it even normalizes it, whereas it's actually the anabolic steroids that mess up the lipid panel.
I recall seeing a discussion specifically on testosterone as well, right?
No, about testosterone, there was a whole discussion about testosterone, damn it. This is what they call evidence-based medicine, fucking idiots. The very first scientific studies on testosterone, because of which it was made inaccessible. This happened in America. Do you know exactly what they did? They took a large hospital and collected all the medical records. So I don't even know if it was doctors who did this or not. I mean, these were actually some kind of, actual bookworms. Yeah. So what did they actually examine in this study? Huh? They looked at which patients were prescribed testosterone and when they died from cardiovascular causes. They didn't look at the lipid profile results, and they didn't look at the patient themselves, like whether he had symptoms of metabolic syndrome or not. They didn't even know the blood pressure readings of these patients. Moreover, they didn't even know if the patient actually took the testosterone, because all they had was a brief note that it was prescribed by a medical professional.
And there was a correlation, right?
And there was a correlation that supposedly those who were prescribed testosterone died more often, and significantly so. That is essentially it. And based on this study, all of this nonsense about testosterone really started. That was back in the year 2013 or something like that, somewhere around then. You see, can you imagine how, well, later this study was totally trashed, of course, as much as possible, but still, based on it,
The residue remained?
so things like this do happen.
2 lipid profiles are about the same in terms of the red flags, right? Imagine one individual who is just, 40 years old, and the other person is only 30, but he is regularly using anabolic steroids. Which one of them is at a much greater risk, and whose overall physical condition is worse? This one doesn't take anything, he's just 40 years old, and this one takes anabolic drugs, substances that provoke issues.
And both have the same cholesterol level.
Both are bad, and equally bad.
So the risks are the same.
Well, but the cycle doesn't last forever. Here we fully understand and identify the cause, and in a couple of months he'll stop taking anabolic drugs, so to speak. And most likely his condition will return to a normal state on its own. But here, you have no idea where this issue even came from, and it's going to last for a long time. But accordingly, in the long term, I would suggest that this one, if his condition normalizes, is probably not quite as dangerous, as long as we know the specific provoking cause.
No, the longer you continue to live with consistently high levels of bad LDL and ApoB, the worse the risk to your health becomes accordingly. And when your plaques rupture, like say you catch an inflammatory illness like COVID and suddenly something sticks to the wall of your blood vessel, who the hell knows when that's going to happen? So it's a multifactorial story. That's it. But honestly, I don't really see many people these days who get off a performance cycle for a long enough duration. for everything in their system to fully normalize. I mean, most people either immediately, well, I mean, some people still do PCT. I don't fucking know. I do PCT myself.
I have heard all of these same old stories so many times now. Honestly, I think I will just try it out for myself. Just this one single time. I say, do you know how many people like that I've heard? I'll try it just once. I say, that's it. You're already one of us, damn it. That's it. You're ready. This just once. I don't know what has to happen for someone to really try it just once, and that's it.
Yeah, that is how it usually goes. That is why I always, tell people, I say, we will get off, of course, absolutely.
Yes, absolutely. Of course, that is definitely true. Friends, as always, incredibly informative. Couldn't be any other way. From Pavel Popov about statins, atherosclerotic plaques if they occur, lipoproteins, and new diagnostic methods. It turns out what's important and what's not. Very important. I didn't even know myself. You know what else?
This is important.
Yes.
C-reactive protein.
Get it tested.
Yes, now it's an ultra-sensitive method. The C-reactive protein marker. Now it is widely believed that soon it will attain the same level of clinical evidence. That there will be vascular damage, just like with low-density lipoprotein. So you can add C-reactive protein to that as well.
And just as a final note, here's the latest information for you. New diagnostic methods. Turns out I didn't know this myself, but I'll actually start using them because this is extremely useful information about diagnosing dyslipidemia. Which indicators are truly important and which are not. In my opinion, it's all explained very clearly, as always. So friends, don't forget to show some love and appreciation. Drop a few comments down below and take a look at the useful links. And by the way, I recently noticed that you're trying to get your daily diet back on track a bit, finally. And increase the amount of protein in your diet. That's why this jar is here, so to speak, not by accident. So since you need to up your protein intake, here's a little gift from us. I
approve. Thank you.
That's all, friends. That's it for today. This was Living Steel. Goodbye.